All right, good afternoon, everyone, or of course, good morning if you happen to be joining us from the West Coast. My name is Deanna Fenton, Program Manager here at the Alliance. And as always, it's my pleasure to welcome you to today's conversation, which will focus on the ever-evolving topic of COVID. Now, over the course of today's discussion, we'll explore the risks of COVID transmission through donation and transplantation and examine what specific conditions might be appropriate to use organs from COVID-positive donors. Now, before I turn the floor over to the wonderful Candy Wells, who will be moderating today's program, please allow me this opportunity to review a few quick reminders with you all today. Now, for those of you who are joining us for the very first time, please note that your audio lines have been muted and will remain muted for the duration of the program. Now, having said that, we'd like to encourage that you submit any questions that you may have through the chat feature, which is located at the bottom of your Zoom window. If you submitted questions during the registration process, please know that we'll do our best to address them over the course of the discussion and during our open Q&A period. Of course, should you have any additional questions, please feel free to submit them at any time using that chat box. Now, as a friendly reminder, there will be no continuing education credits offered for today's program, but you will still have an opportunity to claim a certificate of attendance and provide us with your feedback through the post-event evaluation. An email with detailed instructions on how to do so will be sent to your attention following the conclusion of today's discussion. As always, we will also be recording today's presentation, so if you or a colleague is interested in reviewing the discussion at a later date, you can access the on-demand recording on our website at organdonationalliance.org. There you'll also find information about our remaining programs for the year. Lastly, for anyone that may be joining us as a group, please take this opportunity to complete this poll to indicate approximately how many people have joined your group. And with that, I'd like to go ahead and officially welcome our moderator, Candy Wells, who serves as the Director of Organ Utilization at Life Center Northwest. Candy, it's always a pleasure to have you with us, so thank you for joining us again, and I'll leave it to you to go ahead and get us started.
Great, thank you so much. Welcome everyone to this session. I have the privilege of moderating this session and introducing our accomplished speaker, Dr. Limaye. Dr. Limaye is Professor of Medicine and Laboratory Medicine and Director of Solid Organ Transplant Infectious Disease Program at the University of Washington in Seattle. His clinical and research interests are in viral infections and transplantation. He's partnered with Life Center Northwest to evaluate organ donors with infectious related issues and has developed protocols and guidelines to optimize the standard optimize the standard processes and optimize the safe use of organs from organ donors who in the past may not have been considered suitable for donation. In this session, Dr. Limaye will discuss the risks for transmission of COVID to recipients of organs from donors with a history of or active COVID infections. The goal of this session is to discuss under what specific conditions is it appropriate to use organs from COVID-positive donors and to describe the potential benefits versus risks in those situations. Dr. Limaye will present first, and then we'll have an opportunity to have a conversation and address your questions with Dr. Limaye at the end of the session. And it looks great. Dr. Limaye, your presentation is up and ready to go. So thank you if you want to begin.
All right. Well, welcome everyone who's joining virtually. It's a pleasure to be part of today's conference, and would like to extend a thank you to the Alliance team for the invitation and for Candy to agree as being the moderator. As Candy mentioned, this topic of SARS-CoV-2 infection and organ transplantation has become ever more important with the pandemic. As I'm going to point out, there are a number of reasons why the topic and the overlap between SARS-CoV-2 and organ donors has become ever more relevant. And just to make sure that everyone has their homework cut out for them, after attending today's session, I would expect that you should be able to list the specific changes in the epidemiology of SARS-CoV-2 infection that have impacted organ donors and donation specifically. I'd like you to be able to summarize what the available and rapidly evolving evidence is regarding the risk of SARS-CoV-2 transmission with organ donation and how it might differ according to organ being considered for donation and transplant. I'm going to take you through in a very detailed manner what current AST UNOS guidance is on the use of organs from donors with SARS-CoV-2 infection, and point out areas where there are gaps in our knowledge that make the guidance from AST and UNOS fairly open-ended and leaves it up to individual transplant programs to make a determination of risk benefits in those particular situations. And then finally, I'd like to highlight how an infectious disease evaluation, a very detailed assessment of the laboratory and clinical data, can be used to assess whether a given donor who has a positive SARS-CoV-2 test might be suitable for use of organs without the risk of SARS-CoV-2 transmission. I'm going to talk first about the evolving epidemiology of SARS-CoV-2 infection. Many people have seen these sorts of maps, but there's a number of reasons why that intersection between SARS-CoV-2 and organ donation has been getting larger and larger. We unfortunately are experiencing in many parts of the US as well as worldwide continued high rates of infection in many communities. And some of the reasons that have been postulated to explain why that's happening are summarized here, including the fact that vaccination rates are far less than we would like them to be. There's very interesting data suggesting that as you are further and further from the time of vaccination, that your immunity may wane. And it may be time from vaccination combined with a differential impact of how the vaccines work against Delta versus other variants. We know that many places are opening up or already have opened up, so the opportunities for social interactions continue to increase, including school openings. And then, as I alluded to, the Delta variant has changed the dynamic quite a bit based on various lines of evidence, with higher viral loads being present and likely greater transmissibility of the Delta variant. There's also been a significant shift from older persons to younger persons with SARS-CoV-2 for a number of reasons, and that also disproportionately impacts the field of organ transplant because on average, donors are younger than the population as a whole. There is now ample evidence that even though the vaccines are highly effective in preventing the most serious forms or manifestations of infection, hospitalization, death, mechanical ventilation, they're not perfect. And we know that vaccine immunity wanes either because of time or as a result of differential activity against variants, including Delta. And we have to keep in mind that all vaccines, including SARS-CoV-2 vaccines, are less effective at preventing any infection than they are in preventing the most severe manifestations. Additionally, because testing is now routine for admission to the hospital, we're finding many incidentally diagnosed SARS-CoV-2 infections in the course of evaluating donors who might not have otherwise been tested because they had no compatible signs or symptoms. And this was an issue that our group recognized very early on in the pandemic, along with many other investigators. And we actually wrote a fairly controversial personal viewpoint at the time. And I'd like you to pay attention to the dates. This is more than a year and a half ago, where we carefully considered some of the aspects of the use of SARS-CoV-2 positive donors, and essentially came to the conclusion at the time, we shouldn't just say no. And in fact, with the available data, clinical considerations, biology from other viruses, we came to the conclusion that non-lung organs would be very unlikely to transmit SARS-CoV-2 to recipients in the organ transplant setting. And we also made the point that because of the urgent need and attempt to balance risks and benefits, that having SARS-CoV-2 detected in a potential donor should not in and of itself be an automatic rule out for donors, which I can tell you after responding to the comments of the editors and the reviewers was highly controversial at the time. We did think through this very carefully, and we came up with a paradigm or framework for what some of the arguments are in favor of considering organs from SARS-CoV-2 infected donors, as well as potential arguments against using organs from such donors. and looked at these in multiple individual domains, including the clinical arguments, clinical domain, clinical considerations, systems considerations, and then in the next slide, things such as liability, financial considerations, and other considerations that should go into a thoughtful consideration of whether to use organs from a SARS-CoV-2 infected donor. And I'm not planning to go over each of these in detail. I just wanted to point out that this is a complex decision with incomplete data, but there are very compelling reasons we think that we shouldn't automatically rule out SARS-CoV-2 infected donors. And just to complete the sort of framework for thinking about the arguments that both support the use of considering such organs along with arguments against, these are the domains that encompass financial considerations, liability considerations, as well as importantly, ethical considerations for using such organs. And I would encourage those of you who are interested to see this paper by Olivia Cates published in AJT almost a year and a half ago when we had far less data. And I can tell you with the available data that I'm going to go over with you in the next several slides, we now have multiple lines of evidence, limited as it is, suggesting that some of these earlier contentions and assessments have actually been borne out now by at least some evidence from multiple studies. So what are the studies suggesting that we could potentially use organs from donors who test positive for SARS-CoV-2 in various scenarios of having active infection, resolved infection, persistent RNA present? And I'm going to take you through 5 specific lines of evidence from studies, small as they are, that support the basic premise that the risk of transmitting SARS-CoV-2 from non-lung organ donors, if it occurs at all, is a very uncommon event based on the numbers in the studies that I'm going to show you. So the first line of evidence is that we have, and I think one of the more compelling lines of evidence to me is the observation that SARS-CoV-2 was not transmitted to non-lung organs from donors who ultimately were found to have real active SARS-CoV-2 infection. And this happened when we means the field, inadvertently used lung organs from 3 separate donors who at the time were nasopharyngeal swab PCR negative, but subsequently, before it was routine to also test a lower tract sample, in retrospect, were sputum PCR positive. So these organs were used before implementation of routine lower respiratory tract testing. So these persons had lower tract lower tract SARS-CoV-2 infection documented virologically. And interestingly, none of the 6 non-lung organ recipients developed SARS-CoV-2, suggesting that infection was compartmentalized in the lungs. And not surprisingly, all the recipients who had documented infection within the lungs of the donor then subsequently developed infection of their lungs after transplant. So again, the point was that in non-lung organs, even from a donor who had real documented active SARS-CoV-2 infection, there was no transmission. Keep in mind, this is 6 persons, not 6,000 persons, but this is the nature of the evidence that we have. More recently, we have evidence published from Christine Cova and her colleagues at Cleveland Clinic, where they intentionally used organs, including 10 kidneys and 2 livers, that were procured from 5 deceased donors who had SARS-CoV-2 infection documented by PCR. And in this study, there were no transmitted infections. The outcomes were excellent because it's important to keep in mind there's the issue of potential transmission of SARS-CoV-2, but there's also the concern that viral infection may otherwise damage organs through cytokines or other inflammatory pathways. So it's important to look beyond just transmission to also how the organs functioned in recipients. And the punchline here is that the outcomes were clinically very favorable. And there is now unpublished data suggesting another 40 cases have been performed, again, without transmission and good patient and graft outcomes, although those data haven't yet been published. Third, we now have data published within the last few months from a center in Italy, which was one of the major areas of SARS-CoV-2 pandemic early on. And they published their experience with 10 brain-dead liver donors who had lab-confirmed SARS-CoV-2 infection, 5 of whom were positive in nasopharyngeal specimens and or pneumonia, and 5 who had confirmed lower tract infection. And again, there were no transmissions documented to liver recipients. And since then, they have experience with 9 additional donors with no documented SARS-CoV-2 transmission. The fourth line of evidence is a single case report of a living liver donor in South Korea who had mild URI symptoms after the fact, had SARS-CoV-2 detected in a nasopharyngeal specimen and did not transmit SARS-CoV-2 to the recipient, her mother, who received the living donor liver transplant. So again, reassuring that this stacks up well with the other evidence suggesting non-transmission with non-lung organs. And finally, there's evidence from investigations from CDC and the Disease Transmission Ad Hoc Advisory Committee, where 8 organ recipients who developed SARS-CoV-2 very early in the post-transplant period and were specifically suspected as having donor-transmitted infection were intensively investigated. And the determination from CDC and the epidemiologic investigation was that these were probably community-acquired rather than donor-transmitted infection. So again, 5 lines of evidence, and there have subsequently been even more papers, including day before yesterday, also suggesting that transmission with non-lung organs does not occur commonly. It's never been described, but since the N is relatively small, you can never say never until you have data from literally hundreds or perhaps even thousands of such donations. And just to put this into perspective, in my work collaborating with Life Center Northwest, the number of consultations that I've been involved with over a slightly more than 6-month period of 49 individual infectious disease consultations, almost half of those consultations revolved around COVID in its many forms, from persons who were thought to have active COVID, those who had resolved COVID, those who might have had false positive PCR tests, and then several we couldn't determine definitively whether active SARS-CoV-2 was present or not, despite a positive test. So just to share with you actual personal experience with a very complex case and how we went through it, how we evaluated the data, and ultimately how the case evolved and the outcomes. I'll share with you a case without any identifying details and what the outcome of that case was. I was asked to consult on a young potential donor who was declared brain dead because of an unexpectedly positive SARS-CoV-2 test, which is a fairly common scenario now with routine admission testing. This young man had developed a primary central nervous system problem that led to brain death. His admission, nasopharyngeal PCR as a standard on admission, was negative. But when the OPO took over the case, just 1 day later, a repeat test now was PCR positive, but a lower respiratory tract specimen was negative. This was repeated on a separate day, and the PCR from a nasopharyngeal specimen was confirmed, making it highly unlikely that this represented a false positive PCR test, which is a very infrequent event. And importantly, a lower tract specimen, this time not an ET aspirate, but a bronchoalveolar lavage gold standard lower tract specimen, was PCR negative. There was no clinical or laboratory evidence compatible with active COVID based on radiology and other labs. And we were left with the situation of trying to interpret what this positive PCR from 2 separate nasopharyngeal specimens meant in a person who was otherwise healthy, at low risk for progression of infection who had no discernible signs or symptoms of infection. And so the recommendation was to not to rule this patient out immediately, but to proceed with additional information. And I provided very specific, detailed recommendations about additional information, clinical information, laboratory information that might help us to better put together the story and make a determination of whether this represented very early infection, perhaps persistent RNA detection from distant infection, or other possibilities that could explain the test results. And these were my recommendations to the Life Center Northwest team. And these are the results as they came in. We knew that the patient had multiple recent exposures to SARS-CoV-2 based on various lines of evidence. We summarized all of the PCR testing results, which were summarized in the earlier slide as well, showing repeat positive specimens from the nasopharyngeal swabs, but negative from the lower respiratory tract. And here, the recommendation now to further interpret this was to obtain serology for SARS-CoV-2 to try and help determine whether this was very recent infection where there wasn't yet seroconversion, or whether SARS-CoV-2's seroconversion had already occurred, suggesting that infection was likely at least 10 to 14 days earlier, in which case the likelihood of transmission based on current CDC criteria would be much lower. So in the meanwhile, the patient was treated with remdesivir and monoclonal antibodies as yet another measure to potentially reduce the risk of progression of infection. And the serologic results came back as being positive both to spike and to nucleocapsid, both of which are compatible with prior infection that had likely occurred at least 10 to 14 days ago. And in that case, this serology in the clinical circumstances, even though they could potentially be interpreted in many different ways, was that this was persistent RNA detection without actual active, likely transmissible COVID, particularly with non-lung organ donation and transplant. And so my interpretation was that this would not be a contraindication to using non-lung organs, and that even for lung organs in this case, because of a BAL that was negative, because of the absence of radiographic or clinical evidence for lower tract infection, that could be considered on a case-by-case basis with perhaps a critically ill patient on ECMO who might not otherwise have an opportunity for an offer. And I'm happy to say that the outcome was that multiple organs were ultimately used from this donor, including the heart, liver, both kidneys, and there was no evidence of transmission of SARS-CoV-2. And the organ function, as we know it during follow-up, has been good. And the key points are that all of us in the field are seeing more and more similar cases. And it really behooves us to do a detailed, deep dive into these cases to try and determine whether there are at least a subset of donors who might be appropriate to consider for donation, with the understanding that the risk might differ for non-lung compared to lung organs. So what are some of the considerations other than simply transmission of SARS-CoV-2 with organ donation? Well, I think there are a lot of issues related to logistics and operational issues. What about the use of infection prevention procedures such as airborne precautions that would be required for staff during procurement and transport of organs? Are there knowledge or is there awareness by outlying hospitals and staff members that for referrals, persons aren't automatically ruled out if they test positive for SARS-CoV-2, and that these should be made as routine referrals so that a more detailed assessment can be done. We need to consider the safety of procurement teams, and then obviously thinking about potential recipients. Do we need to do specialized informed consent when we have limited information, at least at this point, about what the actual risk might be? So I'm going to take you quickly now through what AOPO, UNOS, and AST guidance is, and theirs is largely based on the timing of infection that determines what the risk of transmission is. And I think one of the more difficult issues with this guidance, helpful and thoughtful and important as it is often we simply don't know when the clock started and when the patient initially acquired SARS-CoV-2 infection. And so although this is helpful information, unfortunately, it only applies to a very small proportion of patients who actually test positive because of the absence of definitive information of when the clock started ticking, which is the fundamental basis for these recommendations. Regardless, they suggest that if we can document that infection has occurred at least 21 days earlier, that even with a positive SARS-CoV-2 infection test, that these donors are very unlikely to transmit infection based on the lines of evidence and data that I showed you earlier. In donors who are earlier, who you know based on timing are between 10 and 21 days, they acknowledge that there is more unknowns whether early infection, the risk might be higher than in persons who are beyond 21 days, which has been defined by CDC as the period that persons would be considered most infectious. And in fact, almost all hospital precautions now, even in a person who might have persistent RNA positivity by PCR, airborne precautions would be discontinued by 21 days. And so in this case, with this earlier timing, they acknowledge a greater degree of uncertainty and leave it on a case-by-case basis, taking into consideration some of the factors that are described here. And then finally, they describe a scenario when the timing is known to be more than 90 days after the initial infection. And here they acknowledge that reinfection has been documented, but typically after 90 days. So a positive SARS-CoV-2 test might reflect a new infection after somebody resolved their initial infection. And so they recommend that while such organs could be used, they should be done with caution, appropriate counseling, and monitoring of recipients. They also describe scenarios, as I discussed, where we don't really know when the clock started ticking. When did their initial test become positive? And in here, these are the data that largely describe the evidence, the 5 lines of evidence from published studies that I described, suggesting that infection in these, or transmission of infection in these scenarios is likely very uncommon, but we have very little evidence and experience to date in this scenario. And then finally, in patients who may have previously been diagnosed with COVID and have resolved, they recommend that those who test positive, who have no history of previous infection, should take into account these considerations along with the considerations that are shown here, in the previous slide, about what that actual risk might be and how to have that discussion with potential candidates or recipients. At the University of Washington, we've worked in a multidisciplinary way to develop a proposal for utilizing carefully selected, I call them COVID positive, but really donors who have various forms of SARS-CoV-2 infection, either active, resolved, or unknown duration, and suggested that careful assessment of the potential risks and known benefits of transplant be taken into account. We've developed initially a 2-step informed consent process, which is very analogous to that which we use for using organs from hepatitis C viremic donors. And we've initially focused on liver organs because of the published experience, but I think this could be applicable to other non-lung organs as well. And we have restricted it to specific donors who we think would have a low likelihood of transmitting SARS-CoV-2. And I think our recommendations internally are generally aligned, although there are some differences between our recommendations and AST ID guidance. We have had our proposal reviewed and approved by hospital leadership. We have developed specific donor acceptability criteria, the two-stage informed consent process, developed a post-transplant monitoring plan, and have also built in sort of a contingency plan that if the never that we think will happen ever happens, that we would be able to intervene with some of the newer therapies, including monoclonal antibodies and now antiviral agents such as those that are developed and have already undergone early clinical evaluations. And in this slide, I've sort of summarized specific scenarios that we would consider use of organs and whether those scenarios are either concordant or discordant with AST ID guidance. And I just include this is included in slides that I'll make available as just a starting point for specific scenarios where we think the risk-benefit profile would be in favor of considering donation, either of liver or other non-lung organs as summarized in the use of livers and other organs here. And just to put this back into actual clinical perspective, the numbers of donors that we've encountered through Life Center Northwest have really increased substantially between 2020 and 2021. And some of the scenarios that we've identified have ranged from what were deemed to be false positive PCR results, all the way to other scenarios where we thought there may be persistent RNA detection from resolved infection, some scenarios where we couldn't actually time when infection had likely occurred. And I just want to point out that the evidence which continues to evolve has shown that there have been no transmissions with carefully selected donors in many of these scenarios. And we're working very closely with organ transplant programs to make sure that they have the detailed information necessary to make a rational risk-benefit assessment for their own patients so that we don't automatically necessarily rule out SARS-CoV-2 positive donors who might otherwise have the opportunity to save many lives and improve the quality of many persons who are in dire need of a transplant. So with that, I'll end. I want to make sure to leave plenty of time for questions and address some of those that have already been submitted. And so I will turn it over to Candy to take us through some of those questions that people have submitted.
Great, thank you, Dr. Limaye. And please put your questions in the chat. We do have several questions that we'll start with that were submitted prior to the session. So Dr. Limaye, can you provide some information about your opinion on should OPOs routinely obtain cycle thresholds when a COVID positive test on their organ donor comes up? And in using that number, should they use it actually to discriminate on whether or not they should proceed with the donor or whether or not they should discontinue that case?
Yeah, that's, you know, I want to give you my perspective on that very important and appropriate question. You know, if you look in the field for using CT values as a routine sort of assessment in persons who you might be caring for clinically, so outside of the donor setting, I think experts recognize the many, many limitations that are inherent in CT values from this platform to that platform. The fact that we don't really have definitive CT thresholds that we say all is clear, we can't have culturable virus. So I do want to acknowledge the many, many uncertainties that we continue to have with the use of CT values. All that being said, I think in this very unusual scenario of donors with SARS-CoV-2 infection, it can occasionally provide some data that might help when combined with the clinical assessment, repeat testing, serology, vaccination status, other clinical, radiographic, and laboratory criteria that can be part of the puzzle towards interpreting what the likely biological scenario is. And I think there have been several scenarios where I can recall that the CT value provided some value-added information to help inform on what the likely biological scenario was. So I just want to say that I acknowledge the many limitations, but I also acknowledge that there may be certain situations where that can provide some useful information. And the scenario where I think it was very helpful was in the ultimate identification of what was deemed to be a false positive test when the CT value was barely at the limit of detection, again, combined with multiple other tests that were negative, the understanding that there had been some change in lots and a concern about possible low-level false positives. So then that data point fit in well when combined with the rest of the data in leading to a conclusion that that was likely a false positive test.
That's great. I always feel like it's complicated.
You're right.
It's a piece of a much bigger assessment.
Exactly.
I'm gonna read some of the questions that are coming through right now and then go back to those that were submitted. So there's a question about, do we know how far out from primary infections these patients were? I think this was referencing some of the research that was the papers that you were acknowledging. And it says, is there a time after their initial positive test we should wait?
Most of the guidelines for defining transmissibility or defining transmissibility by cough, aerosolization, droplet spread, we're talking about transmission with organs. So these are notably very, very different scenarios. And so those 10 days and 20 days really were designed with droplet spread or aerosol spread as the issue being considered for risk. And so I don't know that those same criteria which have been used in those settings necessarily directly apply to organ donation settings. What my personal feeling is that the likelihood that there is viremia and seeding of other organs is very, very low. And so my personal opinion is that the risk of transmission with non-lung organs and potentially non-other GI organs is low, and it wouldn't matter even in persons with active infections who might be during the period, say 10 days, who would be expected to be highly infectious in the setting of droplet or aerosol spread, but would not likely have seeded other organs. And to just summarize data from multiple autopsy studies, the identification of live culturable virus, either by culture or by electron microscopy, has been extremely unusual outside of the lung. And you have to recall that these are autopsy studies of persons dying with widespread organ failure due to SARS-CoV-2 infection. Even in that setting, it's the exception rather than the rule for identifying what's presumed to be live virus in organs. And so with those data in mind, along with multiple other lines of evidence that I pointed out and covered in detail with you, it is my thought that the risk is probably very, very low, if not close to zero, based on those considerations. Again, if we had 10,000 donors that we had experienced, I think one could be more confident in coming to those conclusions. So I acknowledge that my interpretation and my opinion is based on limited data, but it's based on the multiple lines of evidence that I described, what we know about the biology of other respiratory viruses, what we know about SARS-CoV-1 in 2009 and what happened with organ donation, that I don't have reason to believe that transmission risk would be significantly different.
Great, thank you. And this is a question you and I've talked about before. What has been the transplant center acceptance rates for organs from donors who have had a positive test for COVID?
Yeah, that also is a very rapidly moving target. I think as our data show from 2020, it was just say no and they would say no. But I think things have evolved, and our experience already in 2021, the multiple published papers that I referenced suggest that there are many centers who have carefully considered this issue and are now using organs from SARS-CoV-2 infected donors on a case-by-case basis. And so I do think there are centers that do it, and there are still centers that would simply say this is an automatic rule out from their perspective. And we have to acknowledge that everyone is trying to do the right thing with the limited data and the evidence and experience that they have. But I think the fact that it has been done successfully suggests to me that there are more opportunities here that are being made use of.
Absolutely. So when a transplant program actually has transplanted an organ from a COVID positive organ donor, did they consider the recipient and treat them as a positive COVID case? I mean, are there any specific clinical considerations for those recipients that have received COVID positive organ donors?
Yeah, people have talked about that. Could that further reduce the risk of transmission if, for example, the candidate who will become the recipient has either been vaccinated or is naturally immune, or if they haven't, could you reduce the risk further by providing monoclonal antibodies, antiviral therapy? And the numbers of recipients in the multiple published studies that I showed you who had actually received specific prophylactic treatment, preemptive sorts of treatments, has been very, very small. And I think routine use of agents based on the anticipated very low risk of transmission, I don't think is warranted on a routine basis. But it's something that could be considered, because how would you ever show the risk from negligible to even lower negligible is impacted by the use of these agents. So for those reasons, I think it's not something that I have advised our local transplant center to do if and when specific SARS-CoV-2 infected donors are being considered, organs are being considered.
Great. There are a couple questions that relate to the informed process with potential recipients. In your experience, or interacting with your ID colleagues at other transplant programs, do you know what the experience has been in and around conversations with potential recipients about receiving a COVID positive, whether that's in anticipation of a future offer or a real-time offer of, we have a kidney for you, for example, from a COVID positive donor? And what the reaction's been, and do you have recommendations on what you believe should be included in that type of conversation?
Yeah, this is a very, very difficult issue. And unfortunately, SARS-CoV-2 has been politicized, is very polarizing. And as soon as the word SARS-CoV or COVID comes up, I think many persons are very concerned. I don't want to get COVID with my transplant. Well, we try and explain that the reason we're doing the transplant is because we don't think you'll get COVID. We don't want you to get COVID from a transplant either. And so it is definitely a work in progress, and how best to try and provide context for organ quality, and that you will live longer and have a greater quality of life from an organ that otherwise is medically appropriate, is very challenging to explain, given just the very sensitive nature of this infection. I think incorporating teaching into the initial transplant teaching, here are the kinds of organs. We sometimes get organs from persons who might have risks for bloodborne viruses, for example, just couching it as the types of organs that may carry risk is easier, I think, for patients to think about, seek counseling from their loved ones, from medical professionals, rather than introducing it at the very first time, at the time of transplant, when they're called in and you say, yes, everything, we got a good blank organ for you. Oh, and by the way, the donor has COVID. That's a very difficult time to hear and digest that information. So I think there's a lot of work to be done to educate candidates, persons who are listed for transplant, about the thought process and the fact that other organs carry risk too. from donors who might have risk factors for other lifelong bloodborne viruses like hepatitis and HIV. But that is, I acknowledge how challenging that can be. And if someone has figured it out, please email me at limaye.uw.edu, because I'd love to hear your trade secrets about what was successful.
There's a question. I'm going to take actually two questions and put them together, because I think it's a similar question from the beginning of the process to the end when there's a COVID positive organ donor. So can you speak to the risk, perceived or actual, to organ procurement personnel when they're caring for COVID positive organ donors? So those that either have a history of or active COVID. In addition to when those staffs or transplant programs are recovering those organs. And then are there special precautions when those organs are being implanted into the recipient, or should the recipient actually be in isolation after? So it's kind of the same question, but literally OPO staff, transplant center staff, and then the recipient.
Yeah, that's a very important question, and one that goes far beyond just risk of transmission from the donor to the recipient. And involves multiple teams, the procurement teams, the transport teams, the implantation teams, et cetera. And I think it's best to break it up sort of in pieces. And what we have gotten guidance from our infection control team is starting all the way at the end of a transplant center receiving the organs is no precautions beyond routine OR precautions. No COVID specific precautions are required for the transplant teams here at the transplant center, regardless of whether the person, the donor, ultimately had a SARS-CoV-2 infection diagnosed and it was uncertain whether it was active, recent, or resolved. And then the recipient of the organs, similarly here, after guidance and discussion with our infection prevention teams, is not required to be in any precautions, is monitored, again, with the thought process that the risk of transmission is essentially zero for non-lung organs. For the procurement team, you're dealing with a patient who's undergoing an aerosol generating procedure. And if they are within 21 days, we follow the same guidance, and the recommended guidance would be the same as if that person were undergoing a clinical surgery or another aerosol generating procedure, that within the 20 days after infection, regardless of the PCR result, if there was resolution or no evidence of clinical symptoms, that enough time would have passed that the risk of aerosol transmission would be negligible, and the surgery could be done under standard precautions. So it's really kind of how the risk of transmission would be dealt with for aerosol or droplet spread for the actual donor or potential donor, but none of those precautions apply downstream after the organs are procured in terms of the transplant teams. And we've vetted that extensively with our transplant teams, infection control. And I think there's comfort at all levels that that would be safe and appropriate to do in such scenarios.
Thank you. And another kind of related question was about DCD donors. So if you have a DCD donor that has had prior resolved COVID or active COVID during the extubation process, I'm assuming your answer interrelated to the appropriate precautions that you would normally take in that circumstance would also be the same.
Yes, that's right. I mean, you have a patient in front of you. If they are within 20 days of infection, that is an aerosol generating procedure, then they would be in the appropriate precautions. If you had knowledge that you were beyond that period of infectivity, just like we would do a clinical surgery or a clinical aerosol generating procedure beyond 20 days, there are no airborne precautions that are used, only standard and droplet precautions.
Another question. So how does the threat of microthrumbi affect a potential COVID positive donor and the organs that are suitable for transplant?
Yeah, that's an interesting question and an important one, because I wanted to emphasize that it's not just about transmission of SARS-CoV-2. That's obviously an important question. But another important question is organ quality and other sorts of biological processes that have been identified in the context of SARS-CoV-2 infection. And here, I think the premium would be on assessing organ quality in the same way that it would be assessed independent of SARS-CoV-2. And if there were good function of the organs, then the risk of some of those microthrumbi and other sorts of complications, which have been described in people with very severe, widely disseminated persons who are essentially dying of COVID, those are less of a concern in a person, for example, who might have acute traumatic injury or something else, who's at low risk of progressing to severe systemic or disseminated SARS-CoV-2 infection. So that is a consideration, but I think the clinical circumstances, the risk for developing that, even in persons who might not have it at the outset, are things that have to be taken into consideration, but have not been described in the successful reports of organ donation that I referenced and went through in detail. Admittedly, those are dozens of patients, not thousands of donors. And so, like anything else, we have to acknowledge that the evidence base supporting that sort of a scenario are limited.
What would your guidance be for transplant programs that are considering using thoracic organs from COVID positive organ donors? And specifically, if you can speak to considerations around utilizing lungs for transplant from organ donors that have had COVID or currently are testing positive for COVID.
Right, I think lung and perhaps other, by analogy to SARS-CoV-1 or SARS-2009, is that replication targets those organs. The lung is the primary site of infection, as well as the intestinal tract, with many studies showing detection of live virus for a period of time within the intestinal tract. So I think overall, when I'm thinking about a SARS-CoV-2 positive donor, I really am thinking about lung and intestinal organs slightly differently than other non-intestine and non-lung organs. I think there may be scenarios where, for example, the young donor whose case I presented, where every attempt to identify SARS-CoV-2 within the lower respiratory tract were negative, that in that sort of a situation with a recipient or a candidate who's a good match, who's on ECMO and unstable, that might be a risk that might make sense in an individual case-by-case scenario. But admittedly, sort of the bar, I think, for those lung and intestinal organs is inherently different than other non-thoracic organs. And I think heart really is less of an issue than perhaps others may feel about it. Yes, we're aware of myocarditis. There's really not much evidence that viable virus is detectable in the heart, even in persons dying of SARS-CoV-2 myocarditis. It's a very rare complication, and there's no reason to believe that that organ taken outside of the milieu of SARS-CoV-2 infection would necessarily have the same risk for subsequent development of myocarditis as it would if it remained. I had SARS-CoV-2 and then might be at risk because of biological changes that might happen within my body after SARS-CoV-2 infection. Again, limited data, but I think we don't have the luxury of just saying no at the outset, that we need to do a careful consideration on a case-by-case basis of risk benefits.
I keep looking at the clock here. I think we have time probably for one more question, Dr. Limaye.
Okay.
So this reminds me of some of the cases that we've actually worked together and moved forward. So an organ donor that is dying related to the sequela of COVID, but their infection is resolved. In your opinion, are there possible long-term impacts potentially to those organs that aren't yet seen that may be impacted by the transplantation process or later. So essentially, the kidneys that are being transplanted, for example, from these organ donors, do you think there's a potential for later challenges because of the original COVID infection?
Yeah. Oh, we're out of time. That's too difficult of a question.
It's a hard one.
That's a very hard question. I mean, some biological differences between SARS-CoV-2 and other viral infections, respiratory and others, relate to the issue of long COVID. And again, those organs remain in me. And so whatever happened when I had COVID, whenever it was, would those same things be applicable if that organ was no longer in me and put into someone else? I guess there's always the theoretic possibility that that could be the case, but the available data in terms of long COVID, other than lung dysfunction and general fatigue, concentration problems, other very horrible and disabling sorts of symptoms, have not really extended to biologic abnormalities of non-lung organs like worse renal function, that wasn't already present. So progressive renal dysfunction that couldn't otherwise be explained by other factors in the patient. So I tend to think of those as not as applicable to non-lung organ function than perhaps we think about lungs, or we think about systemic symptoms that I just don't think would be applicable. But admittedly, we don't know. It's a potential risk, but we're balancing those risks with known, proven, life-saving, quality of life enhancing benefits, and we shouldn't lose sight of those important benefits when we make that determination in an individual patient.
Thank you. Deanna, do you want to close us out? I think we've taken it right to the end of time. Thank you, Dr. Limaye.
Thank you, Candy. Thank you, Dr. Limaye. I think we could certainly go on this topic for quite some time. I know we received a ton of questions, and I hope we were able to get to a good majority of them. But thank you all so much for joining us. Dr. Limaye, thank you for taking the time to share some of those insights. It was a fantastic presentation. And Candy, thank you for doing a phenomenal job at compiling all those questions and tackling the ones that we could. So I just want to thank you both once again. And thank you to everyone that joined us today. We hope you enjoyed today's presentation as well. And with that, enjoy the rest of your day. Take care, everyone.
Thank you.